It has come,
Okay,
sir.
okay. So I think I will be bit. I will be bit fast because probably in the spine, for the DNB for your MS purpose for the postgraduate, we don't need very high-fi thing. Only if you can diagnose which is the disc, and if the tuberculosis or your metastasis or a tumor, I think it is more than enough for your reading the spine MRI. I was bit very meticulous in how to show your the knee MRI or the shoulder MRI, as because it is very difficult to understand the basic subjects in the knee and shoulder. So T1, T2, remember, simple. If your cerebrospinal fluid is black, it is T1. If your CSF is white, it is T2. And if it is in between, that means you are seeing the star images. So fluid, if it is very, very bright, that means it has to be a T2 image. And if it is black, it is T1 image. I think if you remember this picture only, suppose the disc will definitely there will be a bulge, then this is a disc problem. I will be got bit faster. So T1 and T2, suppose this is a white CSF, so this is a T2 image, this is the T1 image. Okay. And if you see this sort of herniation on the back side, if you see this sort of herniation on the back side, you will know that you see your disc, this thing has to be stopping like this. But if you see this bulge, this triangular part, this is the disc bulge. So this is the your disc herniation. So even these herniation, as you read from your clinical subject, like it can be central, paracentral, lateral, and far lateral. So from these axial cuts, you can know if the disc is here, this has to be central. If it is here, this is paracentral. If it is here, this is far lateral. And if it is here, then it becomes a far lateral. So I think this sort of picture, I think you all can understand which is the and where is the disc is the problem. Okay. So both you have to see in the sagittal cuts, in the axial cuts. And this is the inferior migration. You can see that there are two level discs. And also in your axial cut, why you see in the axial cut? Because you can know which side, right side or left side, and which is the more involved side. Even in the axial side, you can see the facets. Like if you see that there is a hypertrophy of the facet, suppose the disc is there, facet is hypertrophied, and there is a lot of fluid in between the facet, that means you know that this is a degenerated disc, along with that some facetal hypertrophy. Okay. Even in the cervical spine, you can say that there is a multiple level disc. In the dorsal spine, there is a disc. Dorsal disc also you can diagnose. This is the superior migration of the dorsal disc. Okay. Even post laminectomy, sometimes we do if the patient is not been relieved, and there is sometimes we give contrast to see whether there is any infective problem, because sometimes after the disc surgery there might be discitis, which is more problematic. Even the patient is more symptomatic than your disc. So you have to diagnose whether there is a subtle discitis. We give the contrast. We see whether there is problem in the disc material or the vertebral body. So this is the pseudomeningocele. Sometimes you can see this, there is a leakage of fluid, like this way it will come. This is the post discectomy. This is the herniation of the your CSF. Sort of infective changes, or suppose you see, even you can find this sort of shadow, and you can find this, suppose this is the vertebral body, and you can see there is a lot of destruction like this. And how you know that this is a tuberculosis? Because this is theory, probably everybody in your undergraduate also we have taught you that if you see that there is this there destruction of the vertebral body close to the disc, probably you will find that this is because of the tuberculosis or the infection. But if it is in the central in the body, you have to be very cautious. Probably you are not missing any tumor or any metastasis. Okay. Sometimes the hemangioma will look like this white shadow. This is sometimes this is an incidental finding. You don't have to be very cautious. Okay. So this is probably sometimes this is a term the radiology people will follow, the spinal cord injury without radiographic abnormality. Sometimes this sort of spinal cord shadow, this is a block vertebra, you can see, this is a block vertebra. And sometimes you can see that in the spinal tissue or your neural matter, sometimes you can find this sort of shadow. This might be missed if you are not very meticulous in seeing what is the neural tissue is happening. You can miss this sort of shadow. Now you can see this the vertebral body, there is osteophyte, there is disc, and also there is some retrodisthesis in the, also the disc is there and the body has gone back. And so whenever you see this sort of picture, you have to be very cautious, because if you understand the basic pathology, basic reading in the MRI of the knee and shoulder, reading the spinal MRI becomes very easy. Okay, so metastasis, sometimes you see this sort of, you see this vertebra, and if you see the look of the different vertebral levels, the look of the vertebra has completely been changed. And sometimes there is satellite lesion, sometimes there might be some lesion in the ear, and also in the top vertebra, in the dorsal, on the cervical vertebra. So whenever you order any MRI, always you order to your technical guy that I want to have at least one full shadow, full view from your base of the skull to the your sacrum, so that you don't miss any satellite lesion, or you don't miss any lesion. Suppose you, even for a lumbar disc you operate, you can miss a dorsal disc. So that is mandatory for your seeing the spine. This is the vertebra. If you see like this, and you can see this sort of compression fracture like this. Okay, even sometimes somebody is drawing on his drawing is on, so you can see sometimes the epidural abscess will follow like this, and like this you can follow you can see the epidural abscess. Okay, like this one. AV malformation, sometimes we don't see that much, because we are all now not very, I'm not very keen in doing nowadays the spine surgery. So you can sometimes see the AV malformations. So if you just remember what is bright in your T1, what is bright in T2, and you can know how that sometimes, if even in the spine you can do the contrast, just to know what is metastasis, what is infection. Two, three things you will see in the spine, being orthopedic surgeon in your MSK or DNB career. One is the disc, one is the tuberculosis, one is your hemangioma you can sometimes find, or else you can find the epidural abscess, post discectomy discitis, or the tuberculosis, or any other infection and tumor. Even in multiple myeloma, the picture in the MRI will be different. So these are the 5-6 common things that you have to see in your MRI of your spine. I am not going very detailed in telling you the spinal MRI, because beyond these 6-7 aspect, you will be never been asked in your exam in any way. If you can diagnose these 5-6 things, I can tell you, you will score 10 out of 10. Thank you very much for your kind and patient hearing. As because I was too much meticulous to tell you how to read the MRI of the knee and shoulder, I think now the reading of the MRI of the spine become very simple, whoever is attended this class. Kalra sir, so I think the MRI of the spine, I think I took a small lecture only because if you understand how to read the MRI of the shoulder, reading the spinal MRI is very simple. Thank you very much for your kind and patient hearing. I tried to make it simple as possible for all my students and juniors. Thank you.
Just a question to Dr. Gopal.
Sir.
I have not attended the last few classes for a long time, but I don't know any changes are there.
Sir, there were no classes in last 1.5 to 2 months, sir. We had stopped the classes, and this is the class after a long time.
This is the first class.
First class, sir. We had taken a break.
So I have not missed any, eh?
No. Yes, sir. You have not missed, sir. We stopped the classes because the attendance was poor, and we have to really beg to the students for presenting the cases.
But today attendance was all right, I think.
Reason being, sir, I have rather than requesting them, we have started feeding them with spoon. Now this is first lecture. Next 6 lectures will be faculty lectures only. So they don't have to do any homework. And so definitely there is going to be consistently good attendance till such time we will start the case presentation.
Okay.
So whether they want,
Gopal,
whether they, sir.
We have
Gopal,
one
we have
class
to add
every week.
Kalra also.
Sir,
7
sir.
lectures. We have to add Kalra sir also.
Yes, sir.
Yes.
Now two more lectures I have to add, sir. One is Kalra sir's, and I am again going to request you for that dressing trolley and ward round lecture, sir. So 7 lectures are there. One is finished. 2 more lectures I am going to request, sir. One for Kalra sir and one for you, sir.
I have already agreed. Foot and ankle.
Yes, sir. Yes, sir. But one more lecture. I am bit
Okay.
greedy person, sir.
I'll do that.
Yes, sir. And Kalra sir, I will request him after today's class which topic he would like to and his date, sir.
I will tell you within a day or two.
Right, sir.
Okay, sir. Yeah.
Okay.
Right, sir. Right, sir. And sir, date will be after Sivananda sir's class. Sivananda sir, I think your class is on 21st May or 26th May. Sivananda sir.
MRI reading of the knee and the shoulder, I think it was a very, very crystal clear idea given to everybody about how to go about reading this. As Samantha sir was saying, in the reading of the MRI of the spine, I think the student should know 3-4 basic things. One is how to read a MRI of prolapsed disc, which he has shown a couple of examples. Then infective pathologies like tuberculosis, the paradiscal lesions and the psoas abscess in the axial cuts, how you see. And the third, I think the case that many a times people get in the exams is, I think, spinal stenosis. So you should be familiar with the picture of a spinal stenosis, what is the MRI presentation, how there is a constriction at multiple levels because of the thickening of the ligamentum flavum, facet orthopathy, which is facing from behind, and the degenerated disc from the front side. And if you can go through some of the references, there is a concept of what is called as a sedimentation of nerve roots in the axial cuts. In a normal spinal canal, if it is broad, you get sedimentation of the nerve roots on the posterior side because the patient is lying supine while taking the MRI. So all the nerve roots you will find going on the posterior side. And spinal stenosis, all these nerve roots get pushed because there is most of the times the element of stenosis is a posterior compression. So this sedimentation of the nerve roots is completely obliterated. And I think if you get familiar with these pictures, I think for the exams as well as for your day-to-day practice, I think the MRI of the spine reading should be adequate for everybody. I think it was a fantastic class and an excellent beginning. I think Samantha sir as the opening batsman has hit a century directly. And
Thank you, sir.
it is a responsibility of all of us in the future talks. Thank you, sir.
Thank
Sir,
you,
I
sir.
think well begun is half conquered or almost full conquered as far as Samantha sir goes.
Yeah.
I think Kakatkar sir का ही lecture में sentence रहता है. So I was bit greedy and selfish to request Samantha sir to start with. So now I will request Gopa Kumar sir. Gopa Kumar sir,
Yeah.
you are in nutshell all 3 talks. You please sum up or tell us the important points so that students will focus on those points, sir, which is asked in the exam.
Actually, in the first talk regarding the knee, he said everything regarding the basics, like water is white in T2 and fat is white in T1. Then he said the 3 cuts which you usually take, the sagittal, the coronal, and the axial cut. If you want to look for cruciates, look for and the meniscus, you look at the sagittal cut. If you want to see the collaterals, you look at the coronal cut. If you want to see the patella, the medial patellofemoral ligament and the plica, you look at the axial cut. So he has told almost everything. Then he has shown how a meniscal tear looks like, what is a double meniscal sign, what is a ghost sign, and what is a root avulsion, which is now is becoming more popular and asked for the exams, and how to identify a discoid meniscus, how to identify a cyst of the lateral meniscus, and most importantly, how to identify the medial and lateral side by looking at the sagittal, both not only in the MRI but also in the X-ray. That is very, very important. All these points he has clarified. Then he went into the shoulder, and he said what are the usual things that are asked, that is necessary, how to identify the back of the shoulder, the front of the shoulder, how to identify the rotator cuff tear, which is the supraspinatus, which is the infraspinatus, which is the subscapularis and the teres minor. All these he has mentioned. Then regarding the Bungard lesion, he showed that what is a Bungard lesion, what is a reverse Bungard lesion. He did not go into the details as to the types of Bungard lesions and all, but I think the student can read that up. Then he showed us the ligaments of the our shoulder and how the avulsion looked like. And he told regarding the bicipital tendinitis, all the points he has mentioned. In the spine, he has shown us the types of disc prolapse. That is the most common thing that is asked. Then then the infections, the tumors, all these he has shown. But for the spine, I think we need to hear a little more. And I think the students will be more greedy after hearing this class, because they'll be asking for more classes from Samantha Sir. I'm sure.
Whenever you order, I'll be there. No problem.
Because I am greedy. I think you have to take more classes on knee and the shoulder.
Okay, sir. Whatever you will order, I'll be there. No problem.
Thank you very much, sir. I think listening summary from Gopa Kumar sir is actually re-listening the class, which is actually what we say is Gagar mein Sagar. So thank you very much, sir. Samantha sir, there are two questions.
Yes.
One is how to differentiate between osteoporotic as against metastatic collapse in the spine in MRI. And another question is in the knee, in acute trauma, why lateral meniscus along with ACL is more common, and in chronic ACL, it is associated with medial meniscus. So these are the two questions, sir.
Yes, acute injury, as because this is the mechanism, you know, the lateral meniscus is very, very mobile. Because if you remember the anatomy, in the region of the popliteus, this is not attached to the capsule. So the lateral meniscus is very, very mobile. So as because it is mobile in acute ACL injury, the combination of ACL and lateral meniscus is very common. The second part of the question is that why the medial meniscus is more common in the chronic ACL? Only because the medial meniscus is attached to the capsule at the deeper part of the MCL. So this is less mobile. So whenever there is repeated pivoting, the medial meniscus is more torn. So the fixity of the lateral meniscus makes it more prone to be a combination of a acute ACL with the lateral meniscus. And if the less mobility of the medial meniscus make it more prone to be associated with the chronic ACL injury.
Sir, please explain also door stopper effect of medial meniscus, sir.
No, door stopper effect because it is always there with the whatever meniscus is like the medial or the door stopper means that means the posterior horn of the meniscus will not allow the tibia to come front. So this is known as the door stopper effect. So that's why, because of to negate the door stopper effect, during your Lachman, the knee has to be flexed to 15 degree to 30 degree to negate the door stopper effect of the posterior horn of the meniscus. So if you make it extended or if you make it 90-degree flex, your posterior horn of the meniscus will not allow the tibia to confront in relation to the femoral condyle. So to negate that, you have to flex the knee to 15 to 30 degree so that the posterior horn doesn't block the tibia to come forward in relation to the femur, even if the ACL is gone. So this is known as the door stopper effect of the meniscus.
Thank you, sir. Sir, second question is how to differentiate osteoporotic versus metastatic collapse in spine?
Yes, osteoporotic, I told you, because in the X-ray, when you see the osteoporotic fracture, it is like a fish mouth. That means both the superior and the inferior surface of your vertebra will be collapsed. Understood? Same thing you will see in your MRI picture. But if you see the MRI of the metastatic vertebra or a tumor vertebra, the margin of this will be gone, and also there will be problem at the disc side, which is usually been intact in your osteoporotic compression fracture. So if you follow these two important things in your seeing the MRI, you will miss that this is a osteoporotic fracture and this is a metastatic vertebra.
Thank you, sir. Now, in very few lines, Shivananda sir and Uday Kumar sir. Uday Kumar sir, only few lines. Your comment, sir.
Uday Kumar sir is muted. Uday Kumar sir is muted, I think. Sir is muted.
Sir, my comments are over, sir. Shivananda, please comment.
Sir, my comments is also over because it's already time is over.
Thank you, sir.
We need one more talk from Samantha sir on spine.
Okay, sir.
Spine MRI or spine what?
Sir. No, sir. I would like to remodify this subject as a radiological examination of spine, which includes X-ray, CT scan, and MRI. That will be much more understandable because anterolisthesis and retrolisthesis, these are again major issues in spine and basic issues. So I think we will discuss with him, and I will discuss with all faculties also, sir.
Okay. I deliberately kept the spinal MRI bits short as because I have to finish within 1.5 hours. And thing is that spinal MRI is not that being commonly asked. The rarer things is not being asked. Unless you understand how to read the MRI of the knee and shoulder, then the reading the spinal uncommon things becomes difficult. So if you can remember the disc, then the infection, the discitis, tuberculosis, osteoporotic compression fracture, multiple myeloma, and the spinal tumor, hemangioma, and this 7-8 things, your spinal MRI reading is over.
All right, sir. Any other faculty present, but we are not able. I am not able to scroll through the list. Patnaik sir is there?
I think yes.
Yeah. Yes, I'm there.
Sir. Sorry, sir. मुझे पता नहीं चल रहा था. आपकी comment, sir, please.
No, excellent. I'm speechless. I've seen Samantha sir speaking, but it was so informative and so comprehensively spoken, and excellent, sir. As all sirs have told, the presentation and the content is just it's so much of learning for us and revision for us. That is most important. I don't have anything much to say beyond whatever Samantha sir has told. He has completed everything which is required for a postgraduate and beyond also. So I think it's and completing 3 MRI sessions in one go, as one sir was telling, it looked as if we are having the discussion for 2-3 hours, but it was only 1.5 hours, and that's all, sir. I don't have anything else extra to add or say anything. Excellent it was.
Thank you, sir. Male sir is there. Any faculty member which I have missed or I have not, I am not able to identify in the list. If they are there, please unmute and you can speak. I think no one is there. So to sum up, students, I think we all are very lucky and fortunate to have faculties like Samantha sir, Gopa Kumar sir, Kalra sir, Sivananda sir, Kakatkar sir, Uday Kumar sir. I think almost and Mohanty sir also. I think we are very much lucky, and like what I say, uh, talk in on a bigger subject in a lesser time. That means clear, concept based, concise, and crisp. All these C's, they are really helpful to clarify our doubts. So really, we are thankful to you, Samantha sir, and we are more greedy people. We will keep giving you such topics and requesting you for the talk, sir. Thank you from all faculty sides, joints. Thank you very much, sir. Kakatkar sir, I will request you kindly
Thank you, sir. Thank you.
conclude. Samantha sir.
Yes, yes. Thank you, everybody.
Kakatkar sir, your concluding remarks, and then we will conclude today's session, sir.
I think it was an excellent beginning of the joints PG class again, and I am sure the students will take the maximum benefit out of the senior faculty's experience and their words of wisdom, and they should clarify all their doubts in the coming lectures. This is not only useful for their theory, but extremely useful for practicals and for their future practice. I think we are thankful to all the senior faculty for sparing time and coming and sharing their experience with the students and even the faculty members also. I think we